Good afternoon, everyone. I'm Patricia Burke. I'm the Department Head of Pediatrics and Child Health. Welcome to this special edition of CRIM Rounds, and this is in partnership with the Center for Healthcare Innovation. I'd like to introduce our topic for today, Introduction to Implementing Genome-Informed Pediatric Care. Over the last decade, it has become feasible to perform rapid whole genome sequencing for infants and children in time to influence their inpatient management. The area of greatest clinical utility to date has been infants and children in intensive care units with diseases of unknown etiology. And in this presentation, Dr. Stephen Ginsmore will be discussing his experience with genome-informed pediatric care in 3,000 families and at 72 children's hospitals across North America. Can you advance the slide, please? So I'd like to acknowledge that we live and work on the original lands of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, the homeland of the Métis Nation, and the original lands of the Inuit. The Department of Pediatrics and Child Health, as well as CRIM, respects the treaties made on these lands, and we acknowledge that our offices are located on Treaty 1 territory. We also acknowledge the lasting impacts of colonialism and ongoing systemic racism on Indigenous communities. And we recognize that we all have a responsibility to stand against ongoing injustices. We dedicate ourselves to working towards equity, justice, and reconciliation, and acknowledge that this must be guided by the wisdom of our Indigenous community members and colleagues. Could you advance the slide, please? So it's my great pleasure today to introduce Dr. Stephen Ginsmore. He is the president and CEO of Rady Children's Institute of Genomic Medicine in San Diego. And there he is implementing pediatric genome medicine across North America. He has held a number of roles, including D. Lyons Chair in Genomic Medicine at the University of Missouri, Kansas City at Children's Mercy Hospital. Dr. Ginsmore received his BSc, MB, CHB, BAO, and DSc degrees from Queen's University of Belfast, Northern Ireland, and did his residency and fellowship at Duke University. He is a fellow of the Royal College of Pathologists. He was also a Medscape Physician of the Year in 2012 and received the 2013 Scripps Genomic Medicine Award. Time magazine ranked his rapid genome diagnosis as one of the top 10 medical breakthroughs of 2012. And his team holds 2 Guinness World Records for fastest time to genome-based diagnosis, currently at 13.5 hours. So welcome, Dr. Ginsmore, and we truly look forward to hearing your presentation today.
Thank you very much. Great to be with you virtually. I was in Manitoba late last year, and unfortunately, thanks to COVID, was unable to give this talk. So it's later, but great to be with you. I wish we had a start-off slide that acknowledged all of our sins and prior wickedness during colonialism, but we don't. But good for you guys. Thank you for doing that. That was pretty special. All right, so let's get into this. I don't see you. I'm not sure who's on the other end. I'm going to assume that a lot of you are pediatric residents and fellows. And if you're not, I'm sorry, but that's what that's who I'd like to address this to. Here's my conflict of interest slide. I'm the principal investigator on a research collaboration with Takeda Pharmaceuticals that focuses on natural history studies of specific childhood genetic diseases to facilitate clinical trials, identify endpoints and indications. I will not discuss data related to this collaboration or Takeda products. I will discuss a research study that we've just started on newborn screening by rapid whole genome sequencing that is sponsored in part by Alexion/AstraZeneca and Travere Pharmaceuticals. It does not, however, I believe, represent a medical conflict of interest because it does not involve any medication that they manufacture or sell. However, you can take my bits on newborn screening with an appropriate pinch of salt. Okay, what we're going to be talking about today is something that every pediatrician is incredibly familiar with. It's called the Diagnostic Odyssey. This is actually a slide from Alexian because I like it, and it kind of just showcases the world we live in today, that unfortunately parents, families, children go through this horrendous pillar-to-post phenomenon and eventually get a diagnosis. Tragically, diagnoses are made post-mortem. Tragically, diagnoses are made in adulthood for treatable genetic diseases of newborns, infants, and children. We want a world where this slide becomes history, historical fact. The reason why this is pertinent now and was not pertinent, say, 5 years ago, is emphasized here. There has been a remarkable decrease in the cost of decoding the human genome, to the point now that there's really no excuse for not doing it in our patients. It's much less than any other significant diagnostic technology that we use in children. And that's particularly the case in inpatients, and in particular, those in intensive care units, which is really where I'm going to be focusing primarily today. It's also fast enough that you can do it at admission and have a result as fast as you could, say, an MRI. And our knowledge of genetic disease etiology is finally getting to the point where it's medically useful. For many, many years, we didn't really understand enough about these diseases, and we didn't really have effective treatments, and that's changing really rapidly. So let's do two cases together. This is a little boy seen in our emergency department on Sunday night, and this is now 15 months ago. His mom says, "I can't console him. He's really irritable." That would seem innocuous, but fortunately the astute pediatrician in the ED realizes that he is mildly encephalopathic, and also elicits that the family history has a very interesting clue to the etiology, which is that mom and dad are first cousins. On the basis of this, he gets a stat head CT, and panels A, B, and C show this, and this looks like HIE, hypoxic ischemic encephalopathy. It's not. He had a normal delivery, uneventful. There was no hypoxic incident. So he's got something going on in his brain that looks like it's HIE. He's admitted, he goes into the NICU, he's observed, and the next morning we get a detailed family history. And what we find is that he had a sister admitted through the same emergency department to the same intensive care unit a decade earlier. Her MRI is shown in panels D and E. So it looks very similar. And unfortunately, despite a massive workup a decade ago, now 11 years ago, was never diagnosed from an etiologic standpoint, and she died of a progressive epileptic encephalopathy after a miserable year of life. So the team is now thinking about a recessive condition, that parents are consanguineous, and so that raises the likelihood of recessive genetic disease, and that this is probably some kind of genetic mimic of HIE. This is where the story diverges from general practice across North America, and that is that we get a genome sequence ordered immediately. We have set up systems now across 80 children's hospitals, and that includes 2 in Canada, to be able to make this a reality. And typically who's involved are the neonatologists and intensivists. In our hospital, having done this hundreds of times, they can order this. In most other hospitals, this goes through medical genetics, and always it involves some kind of administrative decision, because right now, in general, this is not a reimbursed test, although that's changing. So this is ordered. We have to get permission from the parents. We need blood samples from mom, dad, and baby. Those logistics frustratingly take us 6 hours. And at 6 p.m., we start the sequencer. The good news is that by 7:30 a.m., we know what's going on. Now, in the interim, he indeed has deteriorated clinically. He's now more encephalopathic, and EEG shows that he is having seizures. His diagnosis is indeed an autosomal recessive disorder. Unfortunately, it's one that's treatable. Now, you see this language here? This is the new language of pediatrics. And I hate to tell you this, but we all need to learn this. Autosomal recessive, biotenthymine responsive basal ganglia disease. This is the inheritance mode. This is the disorder name. It's the official nomenclature. This is the gene symbol and the gene name. We need to start to get familiar with these. We need to understand that this and this are associated. And we need to be able to read this. Homozygous means he's inherited a copy from mom and dad. So both copies of his genome have the same lesion. It's a pathogenic variant. It's a single nucleotide change. It's a duplication of a thymidine at position 597 in the coding region of this gene. And this results in the following protein consequence. At the protein level, histidine 200 is changed to a frame shift, which results in a termination. So he doesn't make the protein. So the treatment for this is biotin and thiamine supplements. Now he's seizing. We need to give this via a nasogastric tube. This is a dietary supplement, but we need to get it. We need to crush it up, and we need to administer it through a tube feed. We start that. Frustratingly, again, it takes 3 hours to get that done. By 6 p.m., however, boom, he's back to baseline. He's happy, calm, no longer seizing, and able to breastfeed. Once we've trained mum how to crush the pills and administer them, he goes home. He's doing really well. Time will tell whether he has developmental delay, but we do know he won't recapitulate his sister's tragic clinical course. This is the new pediatrics. In your lifetime, this is going to be normative. Hitherto, as with the sister, these tragic cases went down as mystery diseases, and nobody really understood the etiology. Okay, one more. Very different. This is a 14-year-old cheerleader. She's having supper, she feels dizzy, and then she collapses. Mom feels for a pulse, it's absent, starts CPR, probably saves her life. The emergency medical services run their code blue protocol. She's transferred to an outside hospital. They run their code protocol. She is not being resuscitated adequately. She's rushed to our ICU, and she needs to be put on ECMO because she just cannot maintain her blood pressure, and she's in and out of ventricular fibrillation. Awesome. However, as you all know, this is really just a temporizing measure. We've got a few days, maybe a week, maybe 2 weeks to figure this out and fix her. Her left ventricular ejection fraction is 3%. I don't know about you. That to me is the lowest I've ever seen in somebody who's not dead. And she comes back, this is during COVID, so everybody's getting blanket viral screens as positive for rhinovirus. And the clinical diagnosis is she's got a viral myocarditis, and she started on clinical treatment appropriate for that. However, our NICU and PICU are used to the idea that their best clinical acumen does not necessarily mean that we don't order a genome. Anybody who has a critical illness like this warrants a genome. It's not that expensive. Worst case scenario, you've ruled out genetic diseases that you might be worried about in the back of your mind, and you move on with your clinical diagnosis. In this case, however, she indeed has a genetic disease. Now, it may be that she has viral myocarditis on top of this. That may be the trigger that caused her to have this fulminant episode. However, that's not what's wrong with her heart. That's just a complication. She has an autosomal dominant disorder. This occurred de novo. She didn't inherit it from mom and dad. And what we have found across North America is over 50% of genetic diseases in children are not inherited. They occur de novo. Critically important to take a family history, as the previous case showed. Critically important not to decrease your suspicion of genetic disease because family history is negative, because more than 1/2 of our diagnoses are de novo. So what happens next? This is super exciting. She gets listed that day for heart transplant, and given her situation, she goes to the top of the list. She's matched that day. She gets a heart transplant a couple of days later, and she's home within 3 weeks. She is doing fine. This is an incredible story. This is the future of pediatrics. So, what we've done because of stories like this for a decade is build around this a delivery system. It's a kind of concierge medical system for cases like this across North America. We onboard local NICU and PICU teams. We equip the medical decision-making administrative piece, and then we put it in play. Generally, what happens is it means that we are rushing a small blood sample to our organization. Typically, it's an overnight shipment, and we do our best to get the results as rapidly as possible. And that typically means 2 days, 3 days. If it's not as urgent, we have a slower mode too. And we have learned that it's not enough just to send back a report. We do need this concierge to make sure that diagnoses translate into outcomes that are improved. So we're solving this problem. Children in ICUs who probably do have a clinical diagnosis, but it may not be right. It affects about 2% of children. And the problem is that hitherto, they have undergone the natural history of their condition because there was no means to make a molecular diagnosis unless it was diagnosable, say, by chromosomal microarray, or unless the clinical features were specific for a condition and allowed targeted testing to be done. So we started this, believe it or not, back in 2011. That's reference 1, 4 patients. 3 of them got a diagnosis. And since then, this has been recapitulated, as you can see, in 30 clinical studies. So this now has a strong evidence base. Some of these are randomized controlled trials, like this one and this one. Some of them are implementation studies, so it's moved from research studies to implementation studies in the real world. And overall, 37% rate of diagnosis. So basically, you test 3 kids, you're going to make a diagnosis in 1. Basically, depending on how you measure it, every time you do the test, it influences management. If we're talking about discrete management changes associated with a diagnosis, it's 29%, but pretty much this always has an impact. You're always changing the likelihood of a child having a genetic disease, and even if it's negative, it's very useful in ruling out things that are on your differential diagnosis that are treatable and you're worried about. 18% change in outcome. That's right up there with the introduction of surfactant in the NICU in terms of impact. So let's talk about implementation. I'm sorry, if I had done this right, there actually would be a Canada. we do this at 2 hospitals in Canada, and they're both in Toronto. So Sick Kids is the main one who sends us a large volume of samples. I want to talk to you about Project Baby Bear, because we are now in the US making this something that is being mandated, or at least driven by policies across our very complicated payer system. So a few years ago, the legislature gave us $2 million and said, show us, will this work in Medicaid? Now, in the US, about 55% of NICU and PICU admissions are covered by Medicaid, right? So most of these families, the very moment they get into the NICU or PICU, they become a Medicaid beneficiary because they have really no means to pay their bill. It's a great system, but for that, healthcare delivery would be a mess. So we studied babies admitted to these 5 hospitals, and they represent the diversity of California. If you've never been to California, or even if you have been, you probably don't realize that we have unique diversity. We have a lot of Asian families. We have a Hispanic, Latino majority, and we have very diverse geography. There's vast tracts of California that are agricultural. So people's conception, which is Los Angeles, is not really representative of our state. So across that diversity, we found exactly the same thing I'd shown you, except this was implementation science. So parents did not sign research consent. This was at a doctor's order. They gave consent as you would for any other procedure or diagnostic test that merited getting parental assent, childhood assent, parental consent. So the diagnosis rate was the same. The proportionate change in outcome was the same. Time to result was 3 days. Okay, this is what the legislature were also very interested in, which was, could they afford doing this statewide? And the bottom line was yes, because it's net cost saving. Why is that? Well, basically, many of these children have prolonged admissions because the etiology of their illness is not clear, and it takes a while to get there before you feel confident about sending them home on a treatment regimen. We accelerate that. They're going to rule in or rule out a genetic disease very rapidly. The faster you do the test, the greater the healthcare savings. That makes eminent sense. If it's a 14-day turnaround time, they're basically waiting in the hospital for the result. We don't know how much you actually save because the study terminated only 2 years ago. So these ongoing cost of care savings will accrue for the rest of the lifetime, certainly in a case like the first one, where for the rest of the life, that baby otherwise would have been hospitalized or in and out of hospital. Family savings, you know this. When we treat a critically ill child, we treat a family. Comorbidity is high in terms of the family. So happily, this has gone from pioneering research to being covered by policies. This is the Anthem Blue Cross Blue Shield coverage policy as to who ought to get this. This is starting to become part and parcel of the boards. So this will be working its way into the mainstream. It's now reimbursed in 4 of our states. 2 of these just happened. They all happened in the past 12 to 18 months. So we are rapidly transitioning. We're way behind England and Wales and Scotland and Northern Ireland, where this is already national policy. And at least in Wales for the last 18 months, they've had a national infrastructure to provide this to all of these kids. England is lagging because of COVID, but they are rolling out a national system to deliver this. Okay, we're done. That is really cool stuff. I'll answer questions about it later. Now we're going to move on. What we found when we rolled this out was that the pediatric literature for rare and ultra-rare genetic diseases was a complete pigsty of a mess. Many of these treatments for these diseases had never undergone the type of scrutiny that's normative in internal medicine, randomized controlled trials that are powered and that then go to a governing body like the Food and Drug Administration before you can sell your drug and it's associated with an indication. No, in our world, we largely deal with off-label use of medications approved in adults. Pharmacodynamics, pharmacokinetics have never been done in children. We're not really sure what's going on in terms of metabolism. We make the assumption that it's the same as adults. That's probably not the case, at least in newborns. We needed a fix. How were we going to provide for doctors who had never seen biotin-thiamine responsive epilepsy the tools to enable them to save a child's brain function? So we built a system. I don't need to go into how we built it. What you need to know is the URL. There it is. Please write that down. GTRX, Genome to Treatment, rbsapp.net. I'll send a copy of my slides in, so if you don't get that written down, you will get that. Here's one of the pages. Okay, I'm skipping a ton of stuff, but basically we needed to do this in a manner that people would go, wow, that really is authoritative. It is. The manuscript's coming out in a couple of weeks. I don't want to get into that because it'll take too long. So we've got the disease name, we've got alternate names. As you know, we love to make up names for diseases. And some diseases have 10 names. Glycogen storage disease 2 is more commonly known Pompe disease. This makes everybody confused. We need a singular name that's married to the gene information. So that was the first thing we had to do. Second of all, for many of these diseases, we have never really proven out what the inheritance mode is. Is it always X-linked recessive? Actually, it's not. This needs to be reworded. It's X-linked. If you are a female carrier, because of lionization, you may actually be affected. So this is in the textbooks, and it's not actually correct. We better fix that. You get the incidence. This is the meat, though. For this disease, there are about 15 different treatments, and each of them has its own risk-benefit ratio predicated on the evidence to support its efficacy. And as I said, for many of these disorders, we are relying on cohort studies or maybe even case reports in terms of our knowledge of its efficacy. So that's what this website does. It makes that understandable without going back to the prior literature. If this is an intervention that could have adverse effects, you sure want to know that it's predicated on a couple of case reports, rather than, as in this case, it's in a published clinical practice guideline. You also need to know when it should be started. In many of these diseases, you need to start the treatment, as in the first case, within minutes. Minutes matter. That baby is losing neurons every minute. Spinal muscular atrophy is the most well-established example. We have a life-saving therapy. If you wait a month, you're probably not doing the child a lot of good. That's a black and white statement, so it's sometimes not true, but the bottom line is you really want to make a decision. Am I going to give gene therapy or not, as soon as possible to delivery? So that's this site. It's going to make a huge difference in terms of upskilling frontline MDs to be able to practice like a super specialist. If you have Duchenne muscular dystrophy, you will wind up in the clinic of a super specialist who deals only with neuromuscular conditions, and they will know the allele-specific oligonucleotide and the steroid treatment to start you on. But you don't want to wait for that. It turns out that that steroid therapy, if you can start it immediately, will buy you 2 years of no disease progression. You don't want to wait. So right now it covers only 421 disorders. It covers 1,527 treatments. It's a good start. 106 of those are diets. Sorry, 109. As you can see, over 118 are surgeries, such as the second case. There's also a lot of devices in there, so it's not just medications, you know. Precision medicine for genetic disease covers all of these. We have a commitment to increase this to maybe 1,000 over the next 5 years and to the interventions, and we want to keep it up to date. Okay, last thing I want to talk to you about is newborn screening. So every baby, as you know, gets a heel prick. It depends where you live. In the US, there are 35 core conditions that every baby is supposed to get tested for, and that saves just shy of 7,000 cases of severe morbidity, possibly mortality a year. That's awesome. What's not so awesome is the trend line. This system was not built for this new era of genomic medicine. As I showed you on the previous slide, there are 421 conditions that we have validated as having effective treatments. That means that 380 odd are being missed. Let's fix that. So this is our new use case. It's to not only test critically ill babies in ICUs, but also everybody else. Can we do that? Is it possible? Now, this is bleeding edge research, okay? The rapid whole genome sequencing for diagnosis, that's well established. The evidence is strong. You ought to know about that. You ought to be thinking, how do we implement this? This is going to take another 5 years to get it there, but this is so exciting. I can't help myself. I got to tell you about it. So what we said was, how about we take what I just showed you and modify it so it works for screening. Screening is incredibly different from diagnosis. When we test a baby in a neonatal intensive care unit, as I showed you, the pretest probability of a genetic disease with the indications that we use is 1 in 3. However, the pretest probability that a child who is ostensibly healthy has a genetic disease that has a treatment is less than 1 in 1,000. Maybe it's more than that. That's a good question. We actually don't have strong data to be able to tell us. What that means is that our sensitivity to specificity ratio is crucial. You cannot make a lot of false positives in order to get your true positives. So we need a test that really thinks hard about how to accomplish that. So the first thing we did was to take that system I just showed you and say, how can we build on that to qualify these conditions for newborn screening? So newborn screening indications are quite different from the indications for ordering a rapid genome. This is them, 6 of them. These are based on the Wilson and Youngner criteria, which were published by the World Health Organization, I believe in 2006. I hope I got that right. And they have shaped newborn screening worldwide. And newborn screening covers 140 million babies each year across the world. Amazing. So we took those criteria and applied them to the 421, and we wound up with 388, so 14% were rejected. Not all of them fulfill all of these criteria, but the next several years are going to be research, and so we felt that there were 21% that merited further examination because we don't really yet know the answer to all of these questions. But there were 14 that we just rejected. They didn't make sense in a newborn screening situation. Okay, here's the method. I know it's a busy slide. This is how we decode genomes diagnostically. Let's just walk through this for a second. You get consent from mom or dad. You get a small blood sample. You ship that overnight to somebody like us. We put it on a sequencer, and then we get into what's called bioinformatics. We convert the genome sequence to variants. You and I have 5 million variants in our genome. We annotate those. Could they cause a disease? We then take the phenotype information. We need the medical record. We extract the phenotypes. You know, this person has an ejection fraction of 3%. They just had a cardiac arrest. You plug all that information in, and you then use this information to go through the 7,200 disorders, and a third get a diagnosis. You then use our GTRX system, genome to treatment, alongside this to make sure that you have a super outcome in that baby. Okay, how do you mess with this? So a lot of it's the same. That's the good news. What's different, though, is that we are not looking up all the diseases. We're looking up 388 that we have qualified. It's 388, not 370. It's not quite 1,500 treatments. And for these, we are only looking, actually, the real number is about 30,000 disease-causing variants. And this is done automatically. And then we interpret only the positives, and that gives us a diagnostic report. It's diagnostic as opposed to a screening test, because this piece is where we go from screen positive to diagnosis positive or negative. And, you know, about half of them are going to be false positives when we interpret them. Okay, so it's really similar. It can be done very fast, but it's much, much less expensive. So one thing that we said was, will it work? I told you we got a big problem, and that is, how many false positives do we have? So we used the UK Biobank, which is 455,000 people from England, Scotland, Wales, and Northern Ireland to test the performance. And once we had culled out the bad player variants and corrected the errors, such as dominant to recessive inheritance, as I told you, for some of these conditions, the literature isn't quite right. We wound up with 0.3%, so 3 or 3.6 per thousand positives. Some of these are false positives. We don't have perfect phenotypes in these adults. We then moved on to affected subjects, and very nicely, we have about 4,000 subjects who've received diagnostic rapid genomes. And so we looked at the performance metrics. They are what they are. They're going to get better with time, but it works. Let me just show you a couple of cases. So this is a great one. This little boy was admitted through the emergency department with hemiparesis. His brain scan showed that he'd actually got a large intracranial hemorrhage. His genome showed that he had factor 13, coagulation factor 13A deficiency. He was diagnosed with, after stroking, at day of life 42. If we newborn screened him, all we would have done is given him fresh frozen plasma or cryoprecipitate until we could have gotten the factor 13, either recombinant or concentrate. This would have been done in the meantime, and he wouldn't have had that intracranial bleed. Here's a case very similar to the one I showed you. It's a different cause of epileptic encephalopathy, but it's also treatable. This little boy, it's again as a boy, we diagnosed at day of life 68. And the trouble is, unfortunately, while this is life-saving, he was really, really, really sick. He also had an intracranial hemorrhage. And so it's unlikely that he will have his full developmental potential. OTC. Now, this is screened for by newborn screening, but it's not perfect. As you can see, here's 3 folks who had negative newborn screens. This one tragically wasn't picked up until 2.5 years of age. And in these 2 patients, they're going to need to get a liver transplant. Tragic. So I showed you this on the GTRX slide. And then this is the little baby I showed you at the outset. He was diagnosed at 7 weeks of age. Wouldn't it have been nice to have him never have those symptoms and instead get treatment immediately? So I'm going to finish here. Rapid diagnostic genome sequencing is becoming established as an effective first-tier test for genetic disease diagnosis in hospitalized children, particularly those in ICUs who have a disease of unknown etiology. And having said that, they may have a clinical diagnosis. And so we're all on this new learning curve of going, I have a good clinical diagnosis, but I'm not persuaded that I have ruled out genetic causes. So it's scalable. We can do this in less than 36 hours, 3 to 5 days is more typical. And you can expect 1 in 3 children will receive a diagnosis. We're building out this system. We haven't really got the clinical utility evidence yet because we just built it, but the goal is to upskill docs so they can practice like a subspecialist. And just think, most kids are not admitted initially to a tertiary quaternary referral center. So this is going to play a crucial role in that critical period of time when you go from being admitted to being transferred. And then lastly, I've shown you the promise of being able to catch up newborn screening for this new world of genetics. Let's skip that. These are the guys who did the work. It's not all of them, but it's a lot of them. And this was partially funded by Alexian, as I said at the outset. Adeo Lumen means to God for creativity, ab amicis auxilium. In this new world, it's multidisciplinary team-based research. This is not your old PI-driven stuff, and it involves lots of biotech and pharma companies, as well as traditional funding mechanisms. Thank you very much.
Thank you, Dr. Kingsmore. That was incredible. All I can say is wow. I will check if there are any questions from the audience. I know we have some geneticists here. In the meantime, I have a couple of questions. What about, so your detection rate's about 33%, I believe. What about the detection of illnesses that have no effective treatments? And specifically, have ethicists chimed in and challenged you on that? You're making trying to diagnosing a condition that may not have any treatment, and how do you respond to that question?
Sure, it's a good question. So I would say the majority of our diagnoses do not have effective treatments today. So it's not rare, it's the majority. This is changing, right? Our world is changing because there are now literally hundreds of gene therapies in clinical trials. Spinal muscular atrophy, up until very recently, was a fatal condition. That's changed. So how do we deal with this? Well, we deal with this the way you always deal with stuff in medicine, which is you give the best care you can and you individualize it to the patient. And the great thing is to have an etiologic diagnosis. What that means is you go to the family and you give them genetic counseling, and you start to restore to the parents decision-making capability. Please understand, as long as you're in an ICU, you as the parent do not control the decisions. You're part of them, but you got all kinds of doctors making all kinds of decisions. The moment you know that this is a fatal disease, it's all about, what are your wishes? Should we baptize your baby? Your baby's going to pass. We think your baby will pass in this type of time frame. Would you like that to be at home? You understand this precision palliative care. What a wonderful idea. I got to tell you, the parents who are most grateful to us, paradoxically, are those that we tell them, I'm sorry, we don't have a treatment for your baby's illness. I'm afraid your baby's going to die. But we know it today. Everything we do down the line, do you want a G-tube? Do you want us to tube feed your baby? Do you want your baby on a ventilator? They get to control these decisions. They get to talk to parents who've gone through the same thing with the same illness. It's a completely new world. It's just as powerful for those families. Chances are those marriages may survive. Historically, they didn't. Chances are they may not go bankrupt. Historically, they did. It's wonderful. Ethicists are all over this stuff. There were great fears 10 years ago that this could be a nightmare. Parents can't manage genome information. Nonsense. Of course they can. It took us 10 years of ethics studies to prove it out. But honestly, this is no more complex than asking for an MRI. You just got to do good by these parents. You really got to think through, okay, I found MYH7, right? I gotta counsel mom because it's maternally inherited, and she may develop congestive heart failure. I found BRCA2. I didn't want to find BRCA2, but I found it. It has consequence again for the family. Was it inherited? Do we need to test the rest of the family? There's a lot of stuff like that, but it's not really anything that's truly completely new for medical genetics. It just is more of it than we're used to.
I'm familiar with personalized medicine because I'm a transplant nephrologist, but I've never heard the concept of personalized palliative care. But in this context, it makes tremendous sense. Question from Dr. Bernie Schodecker.
Hi, I'll echo Patricia's comments on the wow factor. I was blown away by this talk, but just to bring it somewhat back to my reality, although certainly in Manitoba, access to genetic testing has improved and access to exome studies has improved and we're getting better, I still live in a world where the government says no new funding requests. And my argument that I can save on colonoscopies or MRIs doesn't hold water because that's a different budget line. So I can't get the money to do the tests I want. How do I make this argument, which makes sense to me, make sense to people who actually control the money?
Yeah, well, we've been in the same situation, right? So it's only in the last year that we now have a policy that says Medicaid will cover this in California. Unbelievably, I mean, it's just mashugana, it's madness, but they're saying it's covered by our DRG, right? Which means no doctor is ordering this. In contrast, Michigan, right across the border from y'all, not quite, but you know what I'm saying. They have a carve-out payment, so they fully reimburse it. Minnesota just passed it, same. They're going to reimburse it. So even in the US, where it's now policy, that does not necessarily mean that hospitals are getting reimbursed for the costing test. What we found is it's a dialogue, right? And what we found is things like Children's Health Associations, CMOs, medical directors. It's a matter of going through that policy thing to actually get a policy be developed and then approved. And that can take a while, but it's happening pretty fast. And there's enough evidence now, as I showed you, that you can bring that to their attention and they have to address it. It's not like it's hope we wish, What I would suggest is, why don't we give you some free genomes up in Manitoba, and why don't we prove this out in a few cases, huh? I would love for you never to have a kidney transplant patient that you didn't pick up before they had renal failure, right? So that you can go, we know how this is going to play out. Your kidney function's still okay, but we know how this is going to play out. At the appropriate time, we'll figure out when we need to do that. But we don't need to wait. We don't need to wait for you to go on hemodialysis. We can have this all teed up,
Yeah, I think the compelling argument to government is the cost savings by upstream diagnosis. We're constantly having to justify new tests or new procedures and make a business case. But the cases that you illustrated very much make that argument. Dr. Greenberg is involved in genome projects, a genome project on the Western Prairies as well. Perhaps you could speak to that just briefly, Dr. Greenberg. You're on mute.
Yeah, okay. So I'm unmuted. Hi, Dr. Kingsmore. Really enjoyed your talk. I work with Dr. Choddiker, Dr. Burke, and through Genome Prairie, which is one of the affiliates of Genome Canada, we have a 3-year funded project called the Omics First approach, using a Canadian Prairie Metabolic Network, but we're very much trying to prove what you said, that doing the omics first, in fact, is better for patients, provides faster diagnosis, better access to treatments, and is in fact cost savings with rapid turnaround times. So we went live in November in 2021, and all is going extremely well. We're still, of course, working with the Center for Health Innovation, working on the analysis that in fact we can show what our hypothesis is. And hopefully in 6 months' time, we'll have better data. Certainly it's encouraging, and we certainly appreciate not just the ability to make a diagnosis more rapidly, but it certainly has a tremendous impact on patients when you can make a turnaround time, in our case, let's say of 2 weeks. And even when you don't make a precise diagnosis, the appreciation that the children and the adults are having access to state-of-the-art diagnostic is critically important for our patients. And that, of course, our diagnostic yield will evolve more with time. So stay tuned as we move forward with our Canadian Prairie Metabolic Network and the Omics First approach. So thank you for a wonderful talk.
That's awesome.
Can I ask a quick question now that Patricia gave me the ability to unmute?
All yours.
My question was, what do you do with your VUSs, especially doing whole genome sequencing that we're going to evolve to with our Canadian Prairie Metabolic Network? You obviously have many VUSs. What do you do with, how do you interrogate these VUSs? And are you going to go back to reanalyze them as you move forward?
Yeah, so VUS, variants of uncertain significance, the bane of a genomicist's life. What this means is that the variant typically changes the protein coding sequence. It substitutes an amino acid for another amino acid. However, when we apply our magic formula, we are not sure whether that's benign or pathogenic, right? That's the problem. Paradoxically, genomes are much easier than exomes or panels. Why would that be? Well, because we have the entire genome, right? So we know we're not looking under a lamppost. That's always a problem when you're doing a targeted test. You're looking at some conditions and you don't have context. In a genome, you can say, I am ruling out everything, right? So that's a big thing. The second thing is we are now getting used to the idea that we report VUS. The question is, number one, does the phenotype fit the disease? Number two, is there a therapy for that condition? If the answer to both of those are yes, we report VUS. Because honestly, VUS are a transient thing because we lack knowledge. And what they really are what we're all used to as doctors, which is certainty. Right? And so hitherto, it used to be, we went, oh, it's a VUS, we don't report that. Instead, now we're saying it's a label. If you have the phenotype that fits and you got variants that might be triggering your disease, and if there's a therapy, you probably want to consider a trial of therapy or orthogonal testing to see if you can turn that from a VUS to not a VUS. Now, they still live on as VUSs forever, unfortunately, until the ACMG changes its criteria. And we have the unfortunate circumstance that many, many parents whose kids have that disease live with the fact that they're labeled VUS. That to me is ridiculous. But as a medical establishment, we haven't caught up with the reality of how do we override the VUS label?
Well, I think the point that you make, and you spoke to this, is that at the end of the day, the clinician, making a clinical decision has to decide whether, it makes the final decision whether or not the variant that's detected is in fact likely the cause of the patient's problems. And especially if, as you say, if there is a therapy that can be tried, then in the end of the day, the clinician makes the final decision.
Yeah, you're exactly right. And the problem we have, which is a transient one, is most physicians have no idea about what you and I are talking about right now. Right?
Well, I've been, of course, many of my colleagues and I on the phone have been at this for decades, and it's still a very steep learning curve. But what you shared with us today certainly helps us on this steep climb.
Thank you. We have time for one more question. Dr. Triggs-Rain.
Thanks a lot. Great talk, Dr. Kingsmore. I really enjoyed it. I was wondering, and this relates to your last comment, what kinds of education or changes to the education of physicians do you recommend? Or do you think there should just be a specialty education that people try to take as a workshop or something? Or should it just be incorporated more into all parts of our medical curriculum?
Yeah, it's a great question. I don't know I can answer it quickly, but it's a big problem. And people who are medical educators need to really think systematically, how do we introduce this from the very get-go? And we got to definitely chunk it and think through how we're going to get packets of this, because different doctors have it's pertinent to a different extent. But certainly all subspecialists are going to confront genetic disease that they may not be recognizing and need to get their arms around this. Certainly intensivists, hospitalists are going to see this in spades. It's probably responsible for if not a majority, but coming up on a majority of admissions. That's just the nature of the beast. It's vastly under-recognized. It's like a giant iceberg, and right now we all don't realize how much is under the water. We are doing case-based learning, right? That's our fix, is our educators will take a case like I just showed you and wrap it into a 20-minute presentation that, it gets both sides of your brain. It's engaging, you saved a life, and you're also starting to message P. C. homozygous, this mystical language which we use to confuse doctors.
Yeah, I think the future of this type of work also rests with AI and being able to categorize and encapsulate it for us, because the field and other fields are just so broad. I don't think the human brain can, without some type of classification, really process the vast amount of information that's now coming our way. So I'd just like to close by saying thank you for this very informative and inspiring presentation. And I'd also like to thank the Center for Healthcare Innovation for their sponsorship of these CRIM rounds. And I think, Dr. Kinsmore, you can expect future invitations to speak at rounds at our center. Thank you again.
My pleasure.
Bye, everyone.